let's see here. Oh, I was already the presenter. There we go. Okay. So I have some neat infection cases. I'm just going to show some of them are a little unusual. So this is, as far as I know, an immuno-intact patient who presented with fever and cough and has this CT scan. And you can see there's a bunch of tiny little nodules, not a very high profusion, but there are a few on most slices. Some of them are perilymphatic. We see some along the fissure, but others are just more randomly distributed. So it's sort of like a miliary light pattern. There's some relative basal sparing, but these little nodules. So I would think miliary fungus or less likely mycobacteria, but an immune competent patient typically would think of a very high inoculation to get miliary pattern if your immune system works. And so they did a workup on this patient, and they actually grew out an organism, and it wasn't fungus and it wasn't mycobacteria, but rather it was a Nocardia species, Nocardia nova, which I think is part of the asteroides complex or related to it. And it's interesting because of this lady's history. So immune intact, which it's very unusual to see Nocardia in those patients unless it's a direct inoculation. And it's been reported, I think, in sugarcane harvesters where they puncture their fingers. But turns out she had recently been composting, and in the notes it said she had been exposed to large amounts of compost relatively recently. And of course, Nocardia is a soil organ. It's related to actinomyces somewhat, but it can be found in the soil. It's not a commensal organism in the human body, as far as I know, so it's not one you just expect to contaminate from skin or something. So presumably she got a large enough inoculum of this Nocardia nova from her compost and soil and stuff to get involvement of her lungs. And I don't know what other sites of disease. I couldn't find any other descriptions, but they're treating her as so-called disseminated. But as far as I could tell, it wasn't any other organs. So an unusual organism in an immunocompetent patient with an interesting history. All right. This is kind of an interesting progression. So this patient, let me get the right scans in order. Let's see, yeah, so this patient presented, that's the wrong radiograph. Here we go. So initially presented with signs of respiratory illness, and let's have the right scan here. Sorry, there we go. And this was the initial CT scan, and we can see that there's a cavity here in the left lower lobe. It's got some necrosis in it, some vessels passing through it, and maybe a few other little nodules, but not a lot going on there. So, of course, when we see cavities, we think of staph and things like that. In our neck of the woods for fungus, blastomycosis is the most likely to give this appearance. It's rare with a histo, which can cavitate, and then we don't see a lot of fresh cocci here. It's usually imported from the West Coast. But this patient actually went on to develop disseminated disease, and you can see this is a radiograph here that shows a very high profusion of tiny nodules. And on this additional CT scan, we can see that all of a sudden now we have a miliary pattern, and even though the dominant cavity got smaller. So this is, I've seen miliary blasto, but I've not seen it sort of morph like along this pathway here. So I thought that was kind of interesting. As far as I know, also immunocompetent. So we do see miliary blasto in patients. So sometimes it's a delay of diagnosis, and it may have already been bloodborne at that time and just didn't present in the lungs. But it's an R differential for miliary disease, and the cavity would really point you towards blastomycosis. Wow. And then this was a cool case. This is a young patient, and you can see has this subcarinal looking dense mass on the chest radiograph. The lateral is backwards, but you can see there's clearly some lymphadenopathy, but it's pretty dense. I think this patient was like 14 or something. You see normal thymus, but then we have this really, really, really densely calcified subcarinal lymph node extending out towards that hilum there. So this is, we've seen this a few times. I've probably seen 3 or 4 cases of this exuberant lymphadenopathy with milk of calcium with histoplasmosis. And there was initial interest in biopsying this, but then we kind of convinced them that you really don't need to. This is just histo, and probably what will happen is it may contract down over time. I have cases of older adults that have this. It's just kind of chronic, and they just kind of hang out there. So for whatever reason,
can I present a potential alternative diagnosis?
yeah.
We have a case that looks like that turned out to be a very, very proteinuous foregut duplication cyst.
Really?
And it's and the question is all of this connecting? Is it all one big structure, or is it separate nodes that are all different? There it looks like everything looks like it kind of connects.
Yes.
And it's like a confluent structure. So
very interesting thought.
I have one case where where it's just the density is most exuberant dependently, it looks like, where it was, we were shocked, like it was really interesting. But he's got that calcified node in the right lower lung nodule in the right lung, so that may go it.
Yeah, and then you've got these calcified nodes here.
He has right other nodes too. But anyways, I saw that.
That's a great thought.
I've seen that too, Jeff. Milk of calcium in a bronchogenic cyst.
Yeah. It was an incidental finding, so I think either way we'll leave it alone. But I've seen this in histo too. But that's a great thought. I do like that as an alternative diagnosis. But I think
I agree with the calcified nodes and calcified nodules, probably all just the same thing. But
yeah. And in my experience, the stuff calcifies faster in kids than it does adults. Adults sometimes I had some serial scans over a couple of years, whereas kids I've seen it calcify in months. All right, I'll just show one more, and this is an interesting case, and I sent this one to David. I was curious in his experience. So this is totally unrelated. This is not an infection case. So this is a 60-something-year-old male with a known diagnosis of scleroderma made by the usual serology and physical exam, and I think this is the right one. Yes, and you can see this is an older scan. This is a couple years ago, and you can see he had some pleural stuff and probably some early lung disease. And then if we jump ahead to let's see, fairly recently, this has progressed rather quickly, and clearly an NSIP pattern, but it does have sort of a nodular texture to it. And this is where it gets interesting. There's his esophagus. There's no question about the diagnosis. He's on nintedanib and mycophenolate. So nintedanib is approved for scleroderma ILD and then mycophenolate to treat scleroderma. But what's happened also is he's developed bigger lymph nodes, which I can write off to just more lung disease, but he's developing eggshell-like calcifications in these lymph nodes in some areas. Some are more central, but rather progressive lymph node calcification. If we go back to the previous scan from a couple of years ago, there was only faint calcium there. Now, what confounds this case is he's a retired bricklayer. So he worked as a bricklayer for, as all I could tell, that was his job for many, many years. So he was exposed to a fair amount of silica. And going back to the old scan, you really don't get the sense there's silicosis at that time. There's some, these are thick cuts, unfortunately, on this outside CT, but he had some pleural stuff going on at that time. But if you look in the upper zones, it's not what you would want to call pneumoconiosis. But if we go to the newer scan, you kind of get the sense, and these may just be dilated lymphatics, but there's all these little subpleural nodules in the upper zones, but I don't see any perilymphatic nodules anywhere else. But this ground glass does have sort of a nodular texture. So the question is, and as far as I know, he's been retired for several years, so there's no new known silica exposure. Have you seen calcified lymph nodes in scleroderma? David sent me a case report, but the patient did cut quartz for a year. I don't know if that's enough exposure. Probably not. So could it just be related to the autoimmune disease, or could any of these agents, particularly the mycophenolate, which would affect the lymphocyte function, have contributed to somehow an immune response to silica dust, making like why maybe the silica was already in the lymph nodes, but leading to the calcifications? Or have you just seen this as a manifestation purely of scleroderma?
No, I don't think I have.
Can you go to the lower lobes again?
Yeah, it's got the traction bronchiectasis.
And the patient has scleroderma, or
SCL70 and the usual, and it's been fully evaluated.
And they found silicon in the nodes, or they haven't?
No, there's no tissue. He's a retired bricklayer. But what caught the reason I'm pursuing this is this new eggshell calcification or early eggshell. Why is this developing? Because typically we see this with sarcoid, silica, and coal. So the other thing is, could this be a sarcoid reaction from one of the drugs he's on? It has nothing to do with the silica.
I'm sure it's just something related to the drug he's on and some exaggerated response, maybe causing it to by in the silica. I don't know. I think I've never seen scleroderma present with nodes like that.
Yeah, and it's purely academic because his bigger issues is progressive lung disease. I mean, this is rather rapid. So
well, guys, there were articles about scleroderma causing big, juicy lymph nodes back around 1990 and stuff like that. And it's because people were very distracted by that, and so they thought, oh my God, this person has a tumor, or this person has mycobacterial disease, maybe TB. So they were going after these lymph nodes, and it turns out that big plump lymph nodes goes with scleroderma by itself. So you don't need, tumor or infection. So to me, I think that the silica is probably a distraction in this case, and that this is really just calcification in those nodes, because scleroderma is famous for causing juicy nodes. So maybe those nodes have just calcified, and there's just dystrophic calcification, and the whole thing is the result of his scleroderma.
So David, this is one of the articles you sent me from 1990, and you can see there's the big lymph nodes they're talking about there. And they looked at they looked at 14 patients in different big lymph nodes. But what I thought was interesting is this patient, they called this UIP. I'm not sure if I would call this UIP now, but
no, and I think we've all seen big nodes in any fibrotic lung disease, but to see that pattern of calcification, it's not the nodes, it's the calcification I just haven't seen.
Yeah.
But the nodes have gotten bigger too, right? So we're not just talking about the evolution being calcification. The evolution is lots more lymph nodes than he had back in 2019. So he's gotten more nodes, and some of them have calcified.
Yeah. Okay. Well, anyway, I will let someone else go, but I thought you guys would like that case. And I've just not, I've not seen scleroderma progress that quickly, especially to that.
And Jeff, he doesn't have renal failure, right?
No.
Okay.
Yeah, you had asked me about that. That would be another thought too. Yeah, calcium metabolism.
Doesn't have soft tissue calcinosis anywhere.
Just changes esophageal and bad lungs.
Okay, he's not a calcium freak.
Nope. All right. I can't remember if anyone didn't get to go last week or if got cut short. I think Howard and Peter got cut short last week. So one of you want to go?
Okay, I can show a few, Jeff. Just give me 1 second, because I've got a new laptop and I have to try and fix something.
Oh yeah, it may make you log out and log back in if you have to give permission.
Let me try that and see if, yeah, go on to somebody else. I'm going to have to.
Peter, you have cases this week?
Yeah, I got some.
All right. Go ahead.
Most of my cases are stuff that we've seen multiple times, not super uncommon, but just good examples. This one is one I read last week. It's a vascular case. Well, I'll show the, yeah, so this is the most recent case. And the patient has a history of intramural hematoma. The resident I was reading this with asked me if this is a dissection here. So we can go back to the prior. So this is from last week. But we can go back to the prior scan. See which one is which. Not sure what it's doing right now. Okay. So this is the prior scan from, I think it's from December. And you can see the intramural hematoma here on the right side. And as you would expect, on the non-contrast, you can see the concentric high density. So this was just a good example of the entity of ulcer-like projection, a large one there, in the setting of complication of a intramural hematoma. And then also, if you go a little bit lower down, a nice intramural blood pool. So these ulcer-like projections are associated with poor outcomes, and I think the recommendation is or endovascular repair for them. This is the ulcer-like projection here. You can see the broad mouth, and then there's a smaller one there, and then the intramural blood pool, which is insignificant, but really clinically. So good IMH that has evolved and has an example of both of those.
Peter, how extensive was the IMH? How far down does it go?
Yeah, just pull up the so this is the prior, the initial scan that we have. It's a type B, and it starts from the arch. And it goes down to about the diaphragm, which is usually what we usually see them go down at about the renals, or I don't think they go, usually they don't progress further down.
Okay, so it's really a type B dissection, right? And the morphology ultimately is these ulcer-like projections, but
no, it's a type B intramural hematoma here. This one.
That's a particularly nice example. I like that case.
Yeah.
Thanks for sharing that.
And these are kind of like these ulcer-like projections are like described probably about 5 to 10 years ago as a complication of the intramural hematomas.
Right, and the problem is that so many of these kids, I don't know how it is at your institution, right? We have so many follow-ups and we don't have the initial study, and you never know, because you can have a focal dissection that looks like that. I mean, the intramural blood pool helps you out, but the distinction is very important, as you mentioned. One needs to be treated, and has a bad prognosis, and the other, I mean, honestly, if you were just reading this de novo and you didn't have the old study and you didn't have that, and you weren't good, smart enough or quick enough that day to pick up on the intramural blood pool saying that might have been an IMH, you'd say, oh, penetrating ulcer and small focal dissection, and it really is important to differentiate.
Yeah.
well, I would argue that this is really a type B dissection, and its shape corresponds to these descriptions that you guys want here of ulcer-like projections and stuff like that. But I mean, I think there's a big segment of aorta that's involved here. I think that's dissection. So the intramural hematoma was really in a dissection that had not established re-entry.
Yeah, but there's multiple papers showing when this occurs, whatever you want to say, when you have the morphology of an intramural hematoma. I agree that most intramural hematomas are probably a dissection without a exit. But there are multiple papers in the literature showing that when you have this morphology after an IMH, whatever you want to call it, that it portends a worse prognosis and increased risk of rupture, expansion and rupture.
Then just a type B dissection. Then
No, this morphology. So going from an IMH or whatever, a contained dissection without an exit, to this specific morphology where you have a flap and then a broad-based flap and a kind of a wide mouth with expansion of the overall size of the aorta.
Right.
If you put the aorta between the two, you would see it's much bigger. That this portends expansion and rupture. So,
okay.
you know, maybe it is a focal dissection and it's truly the lap, but the outcomes differ.
Yeah,
Okay.
I guess. So with the I guess David, is what you mean is whether this is caused by a tear or just so if there's a tear, it would be a dissection, and if there's no tear, your definition of IMH is if it's just from the vasa vasorum rupture. Is that the?
So what did you say? Fair? I don't understand that word.
Tear, intimal tear.
Oh, tear.
Yeah.
Okay. Yeah. So right. So I think that, I mean, dissection is rarely, well, okay. Fine. We're agreed here. So Seth has added. So I would say that this was a form-fruste type B dissection, but it has evolved in a way that has a bad prognosis and should be treated. Whereas if this were just a simple type B dissection, you would leave it alone. Okay. So I mean, I think we're all together here.
Yeah.
I think the underlying disease was probably an intimal tear. Blood got into the aortic wall but couldn't go out, and therefore you just had a stagnant hematoma. But it has evolved in a way that indicates this aorta is compromised here. You know, it has dilated. We have these wide mouth diverticula, and it needs treatment. So that's fine. I think we're all together on this.
Yeah, that makes sense. Yeah.
Okay.
Okay. This one is just a quick, I'll show the x-ray. Just a nice example of a right middle lobe lobar consolidation. And then I will show the CT. And I like this pattern. You guys can probably see. So this patient doesn't have any risk factors for infection or angioinvasive fungal disease. And I don't remember if it was David or Travis or how, but one of you guys, I like one of you guys, I learned it from you you describe this as a orange pulp pattern.
Blood orange. Travis,
Blood orange,
yeah.
right.
David said, I said orange, David said blood orange.
Okay.
That was, yeah, with the rind surrounding it.
I remember it from one of these talks. And yeah, so this, unfortunately, I don't have the post contrast, but this was a large pulmonary embolism. I don't have the post contrast, but it was confirmed by well, not confirmed, but there's a DVT. There's a DVT, lower extremity DVT. I think the patient had a contraindication for contrast, so we never got the post con.
That's a sizable hemorrhage / infarct territory there. That must have been a big clot.
Yeah.
Yeah, it has that venous infarct look to it.
Yeah. So presumably this is mostly hemorrhage, right? And then it should resolve, and then probably some infarct in there.
It's hard to predict how much infarction is in there and what's going to happen in there over time.
Yeah, but it's very segmental to the lateral middle lobe, and the other segment is okay.
Cool.
This patient has rheumatoid arthritis, and nice example of crazy pavement. crazy paving pattern. He was on Humira, and this is PCR positive for PJP pneumonia. And then he has small effusions, which are probably related to his rheumatoid arthritis, and not usually you don't see. You're not supposed to see pleural effusions with PC or pneumocystis. And then this is the post-treatment. Interestingly, there's this pattern of fibrosis, and I'm not sure if this is from the acute lung injury from pneumocystis, or this is related to rheumatoid, or it's unclear because I didn't have a prior scan before his.
I would bet the rheumatoid. That's a nice rheumatoid-looking pattern there, and I've seen pneumatoceles, but I've never seen like a fibrotic pattern from pneumocystis. Yeah. Everybody else has.
It looks like a HP pattern also to me with some of these lobular.
Yeah. Well, and of course, RA can affect the small airways, right? So that's why it's a good mix pattern. But you're absolutely right. Without that history, HP would be a great thought.
Okay, let's see which other ones. So, oh, this one is another quick one. This patient is a lung transplant patient, I think in 2018. So this is the initial scan from February 17th. And then this is a few days later. So just patchy ground glass. So in this day and age, obviously you think about COVID, but this was rhinovirus pneumonia in a lung transplant patient. And so I don't know prospectively if you'd be able to differentiate this from COVID or.
No, it's an organizing pneumonia pattern. I think that's the argument we've made from the beginning with, when these early papers kept trying to say COVID was, you could diagnose by CT. Now back in respiratory virus season, although we're not seeing much but now that the mask mandates are disappearing in some states, it would not surprise me if we start seeing more flu and other viruses pop up. That's a nice example because it's interesting. I've seen a lot of lung transplant patients where they culture rhinovirus or they PCR it on the BALs, but I never think about it as a common cause of extensive pneumonia.
Yeah, really.
We see it in the bone marrow transplant population.
Mm-hmm. And they've talked about this with COVID, is the hyperemia and vessels are more dilated here in the consolidative areas. Down here, it seems like, I don't know if maybe he has some interstitial edema or something. Usually you don't see that with COVID, as the little septal thickening. But I don't know if that's specific from the virus or if it's just some volume overload also. But prospectively, it'd be hard. And last one. This was a case given to me by my colleague Eugene Berkowitz from one of his multidisciplinary conferences. It was a challenging case. So here's the CT, and history's not super. I can give the history, but it's not going to be super helpful. But you guys have any ideas or guesses about this? Because it was kind of challenging, at least for me.
Smoker?
What's that?
Smoker?
Non-smoker, but interesting. This was
Copa syndrome.
What's that?
Copa syndrome. Isn't that what Travis?
I don't think.
No, seriously, it kind of looks like that with the Zemetis stuff.
I don't think we tested for that, but I don't know. It was diagnosed at an outside hospital as COPD and emphysema, and then the patient came in. So the patient's a middle-aged lady and no smoking history, and developed shortness of breath fall of 2020. And so this was, and I'll show the path. So here's the path. So this is alveolar septal amyloid.
Whoa.
Okay.
And I know David showed a really nice example of one of these where it almost looks like emphysema peripherally and at the lung bases, but it's very impressive cystic change here.
Well, you know,
I hate
it really
that,
is.
but that's what I was
really
thinking
Yeah.
with this basal emphysema.
And then you did show, I had the article here, yeah. So I remember when you showed a case, you pulled up this this case report where they were talking about this. I think this was from a few years ago, but I pulled it back up, so I'm not sure if you remember this article, but let's take a look at the path also. So this is a low mag, and here you can see some of the cystic changes. And then as we zoom in, this eosinophilic stuff that's deposited here is going to be the amyloid. And then they also talked about giant cells. So you can see some giant cells and a lot of amyloid deposition here, and just architectural distortion, and then more high power. And then this is the Congo red with the birefringence.
Wow.
Nice.
It's a really good example
That's crazy.
of protein deposition, the protein deposition leading to the emphysema. And we've talked about that before. It's a really nice example of that.
And
Wow.
she got a bone marrow biopsy also, so obviously they're working her up for she had a paraproteinemia, so this is with light chains, and her bone marrow biopsy was positive for greater than 10% plasma cells, but she didn't quite meet the I don't think they've diagnosed her officially with multiple myeloma yet, and she didn't have any lytic lesions anywhere. So as of right now, this is just AL amyloid, probably systemic, but I don't know if there's other organs yet, and they haven't done a cardiac MRI. So at this point, it just seems like the lungs are involved, or that's the only thing we have evidence for. But it might end up being a multiple myeloma down the line.
Very cool.
That is really
Very committed. Yep.
So all this cystic stuff here in the lung bases, is that just protein deposition? Do you guys have?
Well, it's
obstructing.
lungs being chewed away by upregulation of macrophage-associated matrix metalloproteinases, and that degrades lung substance. So there's a very strong analogy with neutrophil elastase. It's the same mechanism. It's the matrix metalloproteinases that digest the lung substance and produce the cystic spaces.
Very interesting. And that's all I have.
Very dramatic.
excellent. All right, who's
Can I
next?
perseverate about the aorta case one more time?
Of course.
There was this entity, you know, I don't know whether it's still popular, penetrating aortic ulcer, and it was usually sometimes you got an intramural hematoma, but it's very localized, and you would have this little protrusion in one place, and is usually descending aorta, and then with time, that would usually lead to expansion of the aorta at that point, as you'd have a small atherosclerotic aneurysm as on follow-up. It was a very limited hematoma. So what's the current treatment for penetrating aortic ulcer? Not the sort of case that you showed with the extensive hematoma, but a more localized hematoma, a single lesion and stuff like that. Do those get treated, or they just get left alone?
If there's
Usually,
blood, it gets treated.
left alone, I think, is if they're not large. But those are usually from atherosclerotic ulcer.
But that's not always true. If there's hematoma surrounding it, like true blood in the wall, they'll treat that. If it's, especially if the patient has pain. If it's an incidental finding and there's no, a lot of them don't have blood, there's just a little penetration. But if there's from my understanding, if there's blood in the wall surrounding the penetrating ulcer, that's a precursor for bad news. So they will treat that. But a lot of time we see them incidentally in old people, and they just leave those alone when there's no blood.
Thanks, guys. Appreciate it.
Okay, who's next?
I can
got
show
it.
3 quick ones.
Well, that's, yeah, Howard, that's right. You're good to go, Howard?
I'll give it a shot. I hope it's working.
Yeah, usually it makes you do all these permissions.
Let's see if it works. If it doesn't, then we'll do it next time. Okay, let me close that and
Looks like we
that,
see it.
and that. I've already done that part. Can you, geez, seriously,
I see your security and privacy window. Yeah.
can you see my screen now?
Yeah, we can see your,
Yep.
yeah, we see your Cyrex database window.
Okay, so just entirely coincidentally, here is a perfect companion for Jeff's case. So we'll start down here. Incidental finding in a patient with embolism. Here are your calcified granulomas, and you will see calcified lymph nodes in different places, including one just like Jeff showed right there.
That's really impressive. Wow.
Exactly the same, right?
This looks exactly the same.
Yeah. Completely coincidentally, I saw this the other day in a patient with PEs. Okay, just the same thing. Just anatomy now. Let me just show you this here. For trainees particularly, on occasion, in seeing a case like, say, this one, and reading out with the residents, we talk about the pleural fluid, but then I ask them about an interface like this. So here is an interface, opacity, contacting lung in the basal left hemithorax. And we talk about the fact that it doesn't seem to be just that related to the aorta. It's quite opaque, left convex. And then I ask whether this could be related to what we see in the right hemithorax, rather than being any separate pathologic process in the left hemithorax. And the answer is yes. And here you'll see it's produced by enough pleural fluid accumulating in the medial basal right hemithorax that the fluid crosses the midline. Let me show you the axial, and you can see where the fluid is. So of course we have the pulmonary ligament here dividing the pleural space into an anterior and a posterior compartment, but enough fluid has bulged across the azigoesophageal recess, pushed the esophagus leftward to produce that interface in that medial basal left hemithorax. So this is right pleural fluid. And here's a nice companion case to that. We're showing pretty much the same thing. So if you were discussing this case and talking about whether this interface could be related to this in the right hemithorax, yes. So here you see it again, posterior to the lung, pushing the esophagus away and producing this interface in the medial left hemithorax. So pleural fluid can cross the midline like that. Just a nice example of that. Okay, Jeff.
All right, thanks. That's a great radiograph correlation. Okay, David or Travis?
I have some cases I can show quickly.
Sure.
Yeah, Jeff, I still want to show mine that I was telling you about today at the end. So
Okay, yeah, we'll make sure we make time.
I'll show you this, but this is real quick, and then I'll let. So this is a case I saw. I have 2 cases that are just have a lot of interesting findings that keep giving. So this is a transgender male to female. You can see all the silicone injections in the chest. He's got the same thing in his buttocks. People were wondering what this stuff was. It's all silicone injections, not the commercially or not the medical grade stuff. Anyways, so I read this study, and this guy had obviously bulky lymphadenopathy, which itself is not that interesting, but what was interesting is there were air within the lymph nodes. And for the life of me, I couldn't figure out how one gets air within a lymph node unless there is some communication either with a bronchus or the esophagus. So I called up the clinician, very concerned given the location of this, that there was a fistula between the esophagus and these lymph nodes. So that was like a long time ago. I guess the guy came back, which I wasn't even aware of, and they did an esophagram, and you can see, sure enough, that there's oral contrast in the nodes. And here's the contrast portion. And then they biopsied the neck nodes because they kept trying. He was kind of like somewhat homeless, and they were trying to get him back because he kept refusing to come in or canceling appointments, because obviously we were concerned about TB, and this was confirmed to be TB. So this is an esophageal-nodal fistula from tuberculosis. Here is the endoscopy showing the hole in the trachea that went into those lymph nodes, or went from the lymph nodes into the trachea. So I don't know if any of you guys have seen that before.
But to the trachea or the esophagus?
Esophagus. To the esophagus.
Oh, sorry, to the esophagus. Sorry, that was the esophagus. Sorry.
Wow.
It was the esophagus
Wow.
going into the nodes. So I found one case report from like Brazil in the 90s that was about that. So I thought that was pretty fascinating for many reasons.
So Seth, I've seen a case of coccidioidomycosis doing that with documentation on an esophagram. We could actually see the contrast go from the esophagus into the adjacent lymph node. So it occurs with other granulomatous infections, cocci.
Yeah.
Seth, did they test for like HIV or immunocompromised? I'm sorry if I missed.
He is HIV positive.
But what was the CD4 count low?
I would have to pull up. He's
Okay.
not he is. I think he may be in AIDS as well. I'm not sure if he.
I was just curious.
No, but he was HIV. He's like a transgender prostitute that, it's reading his history is quite interesting. And then this case, which came in the other day, which was interesting because I had never seen this before. Not that I think we've all seen these entities separately, but together. So first of all, I don't know why they did this. Again, you don't need two scans to get a combined PE and dissection protocol. But whenever you hear that, you're like, oh, that's just kind of FOS. They don't know. It's going to be negative for both. But this guy, in fact, does have PEs. And you can see they're scattered ones. Plus, he has a raging type A dissection. And let me go back to the PE portion, the aortic portion. So you can see, and it's not only is it just a type A dissection, which is itself, a bad one. He's got tamponade, he's got IVC dilation, SVC dilation, and he also has a shared sheath. So you can see all the blood around the PA and pulmonary vein branches as well. And then interestingly, which they've also, and I don't know where the rupture occurred, but if you look through here, you could see all this soft tissue surrounding the ostium of the RCA, as well as this abnormal kind of soft tissue around the LAD and in the transverse sinus, and maybe some up here, maybe even in the oblique side. It's hard to tell, but that was confirmed to be blood products in the epicardial fat. Whoops, wrong patient. Surrounding the coronary arteries. So somehow it had, partially ruptured, or at least blood had leaked through, and you could see some of that out here. Anyways, I just thought I'd never seen a PE and dissection done and both of them be positive. So thought that was a good case.
All right.
What about the MI? Doesn't he have an MI too? That was a joke.
He may.
That blood sheet, maybe.
Yeah.
That would be
The triple rule in.
Triple rule in, right?
Yeah.
All right. Thanks, Seth. All right, Travis. I know you've got the case of the month, or maybe the year.
I've got yeah. We're going to start with this other one first, because it's amazing that these were on successive days. So this is a guy got hit by a car in 2017, and you can see several rib fractures. This was at the time of the trauma. He's got a chest wall hematoma, and he's got some underlying contusion and laceration of this right lung. So his CT at the time, you'll see that just tons of consolidation here, blood, and I think he aspirated as well, or just all blood. and laceration of the lung. So that's 2017. And then he represents in 2021. He's had some recurrent issues since then, but last month he came in and he's been in the hospital for a few weeks now with hemoptysis. And he's had recurrent hemoptysis for quite a while. And in this case, you could see that he still has this, like, this has been there. And I don't know what you call this, just the residual of the laceration or whatever. But it was noted that he had a couple little blushes, maybe from his pulmonary arteries. But he also has these big systemic arterial, intercostal artery feeders. And you can see some of them coming off the lateral thoracic. And he also has a lateral costal artery, which of course is an anatomic variant that we've talked about before. So he went to angio and they attempted to embolize. First, they did a pulmonary arteriogram, and you don't really see much flow into the right upper lobe. And that's because all of this is systemic to pulmonary arterial venous, or systemic artery to pulmonary artery fistula. So you can see this is just one of them. This is an intercostal artery, and you can actually see right here the flow, the backflow into the pulmonary artery in this case. And so this guy had a whole network of these. This is a different intercostal artery, same thing. You can see another collateral here just rushing into the pulmonary artery, which explains why you're not seeing, you know, the flow on the pulmonary artery, because it's of course going the opposite direction based on pressure gradients. And this is this is the other one, and this of course is that lateral costal artery I was talking about, and then the lateral thoracic or long thoracic, whichever one, I don't remember, but both of these contributing. So this guy's in a tough spot. They tried embolizing him. He's not really surgical candidate, just because I was talking to the surgeons, and you have to go in and essentially dissect every single one of these little transpleural collaterals. Otherwise they bleed like crazy, because this is all systemic artery blood flow. So we know systemic artery to pulmonary artery collaterals exist, especially in the setting of trauma. We could actually pull up some article from some guy named Godwin, was the second author on this. And in 1979, a previously healthy 17-year-old had a tube thoracostomy, but similar things. And you can see the collaterals. And it's interesting, David, I like the VQ scan here, or the perfusion scan, because you see an absence of perfusion, much like the pulmonary arteriogram. So now we fast forward to the next day, and I saw this radiograph. And this radiograph, I'll let you look for a moment. And this is all I had, but it prompted me digging. Anybody want to comment on what they see here?
Give us a second.
There's rib notching.
Right.
Yeah, exactly.
Rib notching,
and it's
the vessels,
super
the
rib
vessels
notching
in the
here.
right upper lobe are abnormal.
Yeah, and it's only in the right upper lobe too. Like I've wondered at first if this fourth rib on the left was, but that doesn't really pan out. But on the right, the third, fourth, fifth ribs, she has a history of intermittent hemoptysis. And one time when she came in, so actually I'll show you an old radiograph, and this rib notching's been there. This is 2006.
Same patient.
That she has rib notching here. But she went to an outside hospital last year, or 2019, I think. No, this is the wrong CT. She went to an outside hospital in 2019 and was diagnosed with pulmonary embolism based on this CT, and you will see all of this crazy network of collaterals. And the reason in her case is not trauma, but she's had prior tuberculosis, and you can see some calcified granulomas and some scar in the right upper lobe. And when we look, you know where this is going. This is the PE right here, or in quotes PE, and this as well. So they interpreted this as acute PE. She was not put on anticoagulation because of her hemoptysis. Instead, was given a DVT filter, an IVC filter. And I don't know, I don't have any imaging of the abdomen to see if it was a retrievable one or not. But what's interesting in her is that they then did a VQ scan a few months later to follow up the PE. And lo and behold, you see that she has persistent defects. So now she's read as chronic PE and referred to our pulmonary hypertension specialist and chronic PE guy. So the reason I actually saw this radiograph was they were doing a follow-up BQ scan, and this was just to correlate the same day to see if her PEs had gone. And so of course this got me very excited. No surprise, on the VQ scan that day, the same apparent defects are there. And of course, with the last case and with the, some of the knowledge from angios and understanding the physiology of this, we can tie it together that there is no PE. In fact, I was able to find an old angiogram from 2013. She had hemoptysis at this time, and check out how well this correlates. First of all, the PA gram, just like in David's article, you'll notice that not only is there reduced filling and reduced perfusion of these areas of the right upper lobe, you can even see a little bit of backflow into the pulmonary arteries, I think, as you go through here, like right in here. You can see goes in and then comes out, back into the pulmonary artery. And in her, this I think is the best one. This is the intercostal artery. And so you'll see that it going out, the rib notching, and then you see these two guys that shoot right back into the right hilum and reflux into the pulmonary artery. And these two do in fact correlate perfectly with the areas that she had the smoke. And so right here and right here are the two areas, and it's basically, stop, I don't want these to link. Yeah, so right here and right here, and I think you can see both of those, it jetting in right here and right here. So I think that, and just to add a little bit of confirmation here, if there's any other, if there are any skeptics out there, which there shouldn't be at this point, but I actually did an MRA the day after that positive CT just to further evaluate these fistulae, and you can see there's no filling defects in here. So this is my favorite smoke case now, I think, that I've ever seen, and it goes to show that they still get misdiagnosed as PE. And in this case, I think we have ample explanation for all of the findings that are seen here. So yeah, I was very excited to call the pulmonologist on this one and tell him that this patient never had a PE and that this is all due to these collaterals.
Will they
Travis,
embolize this one, Travis, do you think?
What's that?
Will they be able to embolize this one?
The interventionalist thinks they may be able to. There were a couple, there is actually, let me pull up the other angio. There was a systemic, there was something coming off the, where is it? I think there was something else coming off of a lateral thoracic artery as well. I don't know if I saved that or not, but she's going to see our interventionalist, and he thinks that he may be able to treat this because it's a much more discrete lesion.
So was this traumatic or is this congenital?
We think this is probably post-infectious. She had TB in her right upper lobe.
She had TB. So this is different than the trauma guy. So the trauma guy and this guy were completely, this woman are completely.
They're different patients, yeah, but exact same physiology.
And the same area too. That's weird.
Yeah.
So
it's
so
weird.
Travis,
What makes the intercostal arteries get big and communicate with the pulmonary artery branches?
In a case of post-infectious, I don't know, but trauma, I think it's the same thing. You get inflammation, just like we see systemic to pulmonary artery collaterals in patients that have chronic bronchiectasis or fibrosis. Cystic fibrosis patients don't get this degree. I don't know exactly why, but it has to do something with the prior insult.
But it's got to be I mean, it's the same, right? It's like fistulas between the TB lymph nodes and esophagus. I mean, it's just, I would imagine cranial inflammation rotting through both and connecting them, and then it grows. That's how.
I think what's key to getting the systemic arteries to invade the lungs is to have inflamed pleura. So if you inflame your pleura, then you get this in-migration of vessels from it. So I think you have to have a peripheral lesion to get the pleura involved.
Yeah, definitely. Well, you yeah.
So
the
Travis,
VQ scans.
was there evidence of the old TB on the CT?
Yeah, there was. She had some calcified granulomas and some scar. It was more in the apical right upper lobe, but she has some mucus plugging and airway thickening, and maybe a little bit of reticulation posteriorly.
and she has that peripheral pleural stuff near the axilla too.
Yeah.
So, yeah, that's the site of invasion probably.
So,
Gosh, unusual. Wow.
That's
But-
awesome.
yeah, it's
So-
just, it's also, yeah, go ahead, Jeff.
I was just say, quick question before we wrap up. So this raises a bigger issue in that we've seen a lot of smoke in this conference, and we've also excuse me, decline scam call. We also wrote a paper on it. So how many PEs out there do you think people have been diagnosed with that aren't real?
Well,
A
so there
few-
was a paper at MD Anderson where they looked at referrals from outside with PE, and they found it was like 26% of all PEs when they reviewed the studies they thought were overcalls.
And that's in a
And
higher risk population too at MD Anderson.
Yeah. And most of that was motion. You know, one
Right.
of my beefs with that paper, it was in AJR, was the fact that they just commented on they just said something like flow artifact, but they didn't really go into detail.
Right. I'm thinking more
But-
like things
yeah.
like yours that for someone who's not aware would call that clot every day.
Yep.
It's not like, oh, it's a.
Well, this was actually,
a
yeah, this was reviewed by someone. This CT was actually reviewed because the pulmonologist said he showed it to someone here, and who said, yeah, this is PE,
I
even
can
though
see
he was
why
a
they
little
would call it.
skeptical.
I mean, I
Yeah.
don't disagree.
Yeah.
It looks a little funny, but I mean,
Oh,
it's
yeah.
not like it's just on one image or something like that.
Right. Yeah, and actually, it's funny you mentioned that because I was pulling up this, Howard. It was actually 7 years ago today. You sent out the first smoke. This is the 7-year anniversary. This was the young woman that had the 2 CTs on 2 different days that you sent out. There's the email from 2014.
I'm impressed you keep your email that long.
Well, it's just in my Gmail archive.
I hit delete all the time. All right, guys. Well, it's top of the hour, but thank you. Those were some really good cases this week, and I
Okay,
apologize.
last
anybody-
question. 2 cases of intercostal to pulmonary artery fistula, one from tube thoracostomy, one maybe from TB. Has anyone ever seen that before in any other situation?
Not that I
I don't
recall.
think I've
Well, this
ever
was-
seen that.
This was trauma,
Yeah.
David, or the other case was trauma. The first one I showed, and David's in that paper from way back when was tube thoracostomy. So I guess iatrogenic trauma as opposed to getting hit by a bus.
So it was tube thoracostomy for a spontaneous pneumothorax in a young man. And so it may have been the pneumothorax that spilled some blood into the pleural space, or it may have been the tube that he got when they evacuated the pneumothorax.
2 in 30 to 40 years. Jeez.
Well, we see these these are like MAPCAs in patients with congenital heart disease
Right.
and other, not exactly like this, but we do see these types of systemic to PA connections, just not usually to this severity.
Right.
Very, very interesting. I wonder. Wow.
Yeah. All right. Well, if anyone, I'm sorry if we didn't get to everybody, but next week we'll start with, if David and I saw Brian had joined in towards at some point, we'll get you guys in next week. But thanks, everyone. Talk to you later.
Thank you.
Thanks.
Bye-bye.
Bye.